You're very welcome back. My name is John, and it's my privilege to chair the second session. Thank you to Dale for her work so far. The previous session looked at the past, and this session is an attempt to do some future gazing to see what we think will happen over the next 10 years or so. I'm very delighted to have a number of guests with us this morning. Oops. My phone is ringing. I haven't turned it off. I don't even know where the phone is. So it's just okay. First of all, I'd like Michelle, please, to come to the floor, and Sharon. Sharon. We're delighted to be joined by two guests physically. I have Michelle Kerrigan here. Michelle is the CEO of GROW. She's also the chair of mental health reform, so a long experience in the world of mental health. You're very welcome, Michelle. Sharon, you're very welcome. Sharon is a newly appointed chair of the reference group, which is a part of the National Implementation Committee for Sharing the Vision. You can explain all that yourself. And Sharon comes again from a world of experience in mental health, and let her explain that herself in your own time. We also have two other panelists who are both online, both affected by COVID. I don't know if you're up there yet, but I want to introduce Jim Ryan. Jim is the operations manager for the HSE in mental health and also responsible for quality and service improvement. So you're very welcome, Jim, to this session.
Thank you, John.
And we also have with us John Farley. John is the CEO of the Mental Health Commission and has previously worked in other regulatory organizations with HICWA, and has a variety of experiences across the mental health and health world generally. So you're both very welcome. You can hear us all loud and clear, everything. Jim, I'm going to kick off this session with your good self, and just to ask you about, based on your experience of the last many years in HSE and in health service development generally, what do you think are the positive things that you would like to bring forward over the next 10 years in terms of your own experiences and opinions?
Thank you, John, and thanks very much to everybody for the invitation in the first instance. My apologies, I can't be there in person. When I was reflecting on the question that was being put to me about the last 10 years and looking forward to the next 10, I suppose I don't think anybody would have believed 2 years ago what we would have been faced with 2 years ago. So planning ahead 10 is very difficult. However, in trying to look at what has happened over the last 10 years that I think have served us well, and that I would hope we would bring into the next 10 years. The first one, from a mental health national office point of view, and my job there as head of operations and service improvement. The first one is that as an organization, the HSE back 6 years ago established the National Service User Office. And that was the first, and even at the moment, the only care group that has a national office for service user engagement and family and carer. And that was, I think, a very good step, and one that showed the commitment that we have to core production in the mental health services. And I'd like to see that develop into the future. Some of the things that has happened in the last couple of years around we having 9 service user leads across our 9 CHOs, plus the establishment of the forums and the establishment of lots of other initiatives like peer support working, recovery colleges, etc. So that's certainly, John, one of the things that I think from an organizational point of view that we would like to see that we would be bringing forward. The way in which we do our business in mental health services on a day-to-day basis has set the service user at the center of the involvement. And that sometimes can be, that is difficult at times, because obviously there are lots of stakeholders involved in mental health services. That's the first one. The second one is a little bit around sustained additional investment, both financial and staffing. And as some colleagues will probably know, we've been in front of the Public Accounts Committee, the Joint Committee in Health recently in relation to the investment made in mental health over the last number of years. And it's probably useful to say that we've had about 450 million of an increase in the last 10 years of a budget in our overall mental health services. And people legitimately say that our percentage spend in comparison to other countries is low. So I understand that, but there are many reasons why we're not always comparing like with like. But 450 million over the last 10 years is a significant increase, which has allowed us to recruit about 2,300 additional posts. And even as we speak at the moment, there are about 619 posts in recruitment. Now, I know if I was talking to Eddie, he'd be talking about, well, what's the outcome? And I completely agree with that. But from my point of view and from my work, I need, in order to be able to advocate on behalf of getting additional funding in the first instance. And so that certainly has happened. And it's also important that we do it in a sustained way. So that will break down about 10 to 50, about 30 million per year. And that's the rate at which we reckon that we can actually spend the money in a way in which is appropriate and effective. Not to mention what we need to do in our capital development, which is a much wider and much more costly and much more, I suppose, at the moment, strategic way in which we do need to invest further. So it's about that, John, that I think we need to have the sustained additional funding rather than having once-off approaches to additional funding, which can be extremely difficult. The implementation of sharing the vision, which you'll be very well aware of as the chair of the NIMC, and again, looking at the structures that we've put in place this time to implement sharing the vision, I think have learned a lot from the original implementation of Vision for Change, plus also the implementation of Connecting for Life. So that I've spoken to Eddie many times about the need for additional investment in the actual implementation science, as distinct not just from the actual writing of a plan, because to be honest, writing a plan is one thing, implementing is very different across 110 general adult teams, 60 CAMS teams, 20 or 30 psychiatry of later life. So the investment that we have made in staffing has been at multidisciplinary team level. I just want to make sure that that point is put across. It's not what people would see as being just doctors and nurses. Much and all is we need doctors and nurses, but it is across social work, occupational therapy, psychology, psychotherapy. So the further implementation of sharing of Vision for Change and sharing the vision is one of the things that obviously over the next number of years is critical. And the last two things are, one is about a responsive and agile service. And if there's one thing we've certainly seen, if there's one of the things we've seen over the last couple of years is our ability as an organization to be agile. As if you look at what we've done in the last couple of years as an organization, 90% of our services were maintained in some shape, particularly the inpatient services on mental health over the last number of years. And that's through the hard work and diligence of our staff, and also about service users adapting in a way that probably previously we weren't sure we were going to be able to do. The point that people were making earlier about online, like today, does this work? It works a little bit. It's not perfect, but it's better than an alternative not having it. And it's a little bit like that we have to do, particularly at primary care level, where many of the services that we do deliver could be done online to a much more effective degree. And the last bit that I just wanted to mention was around the development of the community and voluntary sector. And as you've seen from my biography, I worked with Kerrigan for nearly 10 years. And so I enjoyed that and learned a lot of working in community, where communities feel at times that the statutory services don't know how to listen. The NGO sector, in my experience over the last number of years, certainly has been extremely agile and very responsive. And I see them as a critical partner, to the extent that, as you'll probably be aware at the moment, NOS, the National Office of Suicide Prevention, spends approximately 7 million a year on NGO funding. And at National Office, my office, we have a budget of about 31 million per year to go to individual organizations, not to mention what goes through the individual CHOs. So there's definitely some of the things, John, I hope reasonably succinctly, that I would think have started in the last 10 years, and I think we would need to progress further into the next. Thank you, John.
chance to explore some of those in the course of the next 40 minutes or so. I want to come to you, Michelle. Michelle, you are intimately involved with GROW and with mental health reform. And we heard earlier about the research on Brave New Connections. Perhaps you might just talk about that in the context of the future from your perspective.
Yeah, absolutely. We welcome the report of Brave New Connections. I think there are a lot of learnings in it, but there's also equally, there is a lot of challenges that organizations will face into the future. I think just to look at the positives, you know, organizations really transitioned very quickly onto the online platform, and, you know, great credit goes to all of the teams that were involved in that. It wasn't an easy transition, but it was one that had to be done. Now that we're 2 years into it, it's now time to reflect on what was good and how we can move those good pieces forward, and what areas were challenging. And I think it does open up opportunities for developing new types of services that can allow people to access services from any part of the country. That said, we do have to be mindful of the fact that there is a digital deficit, in the sense that there are many people who cannot, for many different reasons, access the online platforms. And for example, they might be in an area where they do not have you know, proper Wi-Fi systems or internet access. They could also be in a situation whereby if they are receiving support, that maybe the home environment is not the appropriate place, because that's where their issue lies. So going online would not be suitable for that individual. It may also be the fact that they actually cannot, due to maybe age profile. It's not necessarily all about age profile, but they're not technologically apt in getting onto the online platforms. That said, I do believe there is an opportunity for training and development of individuals and communities in accessing support online. We do need to look at the whole area of cybersecurity, because everybody got on very quickly. It was the last thing on anyone's mind. But now that we have settled into the online platforms, we do need to look at how secure our systems are. I think Kevin made reference to the fact that, you know, some systems are not as secure as others. And this will be a time of reflection as to whether an organization is actually on the right platform for security reasons. But that comes with an investment as well. So we're looking at, you know, proper resourcing in relation to funding streams being made available to enable organizations to become more secure in what they're doing. Also looking at their training and development of their own staff, their own volunteers, and training in the broader sense of knowledge base in communities as well. Online platforms, it's not for everyone. We have face-to-face groups, which is our core piece of work. We have found that some people do not like the online platform. So we have to marry the fact that we will be moving forward with the offering of two types of services, face-to-face within the community, and then the online. And it's also how to combine those two and bring, for us, members online and members face-to-face together, because they can be seen as two separate communities, whereas we want them to be integrated and to be able to avail of the social interactions that the face-to-face offering offers to people. So there are things that every organization will have to think about and to try and build it into their strategies as we move forward. But on a bigger platform in relation to policy context, there needs to be a framework around it to aid and support organizations to be able to develop their strategies and support their members. And that can only be done collaboratively, you know, with the HSE, mental health reform is definitely in there as well, and the organizations themselves in how can we move this platform forward. There are benefits for everyone in relation to the online platform, including the HSC, because it is a lower cost. It's a lower cost for organizations as well, and how we can do that safely and securely, but also not impacting on the quality of the service that we are delivering as well, because quality is really important, and that people are getting out of it what they want, and that they feel supported in their journey, whatever that journey may be. So yes, it's exciting. I think the next 10 years will be an interesting phase for all organizations, including mental health reform, in relation to where technology is going to bring us. And I think if we all work together, we can achieve something really superb. You know, we have shown that we can do it, and we will do it. So I'm looking forward to the next 10 years.
Thank you, Michelle. And we'll come back again to some of those issues that have been raised earlier on, and they're obviously live issues. I was going to ask the next question of both Sharon and John. I'm going to ask Sharon first to come to this. I was warned earlier on by Eddie not to be using the word challenges. So the question was about the challenges over the next 10 years. So now rephrasing this to the big issues over the next 10 years in terms of mental health service development and delivery. Sharon, would you make some comment, please, on that? Then I'll go back to John with the same question.
Sure. Just to start off, when I came back from Australia 6 years ago, I remember having a conversation with someone and them saying to me, oh, we're about 10 years behind Australia. So, you know, I hope that's not the case. I don't think that's the case anymore. I think there's been massive progress made. And I'm thinking in particular in relation to recovery-focused services. You know, that was at the infancy 6 years ago, and now it's very widespread. And the whole understanding of recovery-focused services and person-centered services is very well understood. Reduction in stigma, understanding in workplaces, all of those things have progressed very rapidly, I think, across mental health services in Ireland. And again, I totally agree with Eddie, not using the word challenges. It is more about opportunities and how where we see barriers, how we do work around those. There's definitely an inconsistency, I think, at the moment in how services are provided. And unfortunately, there's, you know, all roads lead to the HSE, and that's where we see the bottlenecks in service provision. So I do believe that there's a need to look at how the voluntary and community sector can be resourced to provide mental health services and to be a referral partner in the process. How we do it is very, very important moving forward. We've seen in the disability sector, not only in Ireland, but in many countries, how fragmented it can become very quickly. And that leads down a very complicated path to try and pull it back on track. So we actually have a really good opportunity here over the next few years to think very carefully about how we develop this, how we fund our voluntary and community sector to deliver the services that they're already delivering anyway, to be honest with you. You know, there's services that, speaking for my own organization that I work for in my day job, we've moved from before COVID to no counselling service to now having 2 counsellors in place. I guess the other thing that I want to say is that the opportunities that we have in my role as chairperson of the reference group for sharing the vision are very exciting. You know, there's a lot of goodwill out there, and I've been around the block long enough now to know that I'm not being naive about it. There is a lot of goodwill out there from all sectors of government, the Department of Health, the HSE, the not-for-profit sectors. Everybody wants to do this. Everybody wants to see this succeed. There is some trepidation about how it's done. And, you know, there's a newness, I think, about working in true partnership with each other. But there is definitely a willingness out there to get this done. The fact that there is accountability built into it and implementation science, as Jim says, is being used is really, really important so that it doesn't become another document that sits on a shelf gathering dust over the years. The members of the reference group that I am lucky enough to be working with, some of whom are here today, are an amazing bunch of people. This skill set that they bring to the reference group is going to be such an addition to the implementation of sharing the vision. And we're all very much looking forward to being part of this journey into the future. So I think that's probably enough for the time being.
Sharon, just for people who don't know, just very briefly explain what the reference group is about to do.
Okay, so the reference group is made up of people with lived experience, family experience, lay people who don't have any experience, any lived experience, but have experience of working in the sector or supporting the sector. And our role is to offer advice, information, but more for our own sake is to really challenge implementation and to say, you know, well, this is not going to work for service users or family members, and this is where you need to hear our voice and to work with us to tweak, to change, to make things happen.
Thanks, Sharon. We'll come back again, as I said earlier on. John Farley, I'm going to come to you if you're still online there.
Yeah, thanks a lot. So first of all, the last 10 years, a lot has been achieved. For example, I know we're bringing a new Mental Health Act in, but the current Act has served us well. I worked under the old 45 Act and the current Act. And the current Act has put safeguards in place for people who are deprived of their liberty. There's a lot of work goes on to make sure that rights are vindicated, including at the HSE level, commission level, and the different people who serve on the panel. So we have to recognise that. The second thing is that we've been registering and inspecting inpatient mental health centres for 10 years. And we have to respect the fact that that was put in place as well. And it does show, it brings transparency. And one of the things I want to say to people is, very often as a regulator, you create this transparency and it can give the impression that a specific sector is behind other sectors. And that's not the case, because all you have is that our mental health sector is regulated and there's transparency around what it has to deliver, whereas many other sectors don't have that, if you think of acute healthcare, etc. So it is important to understand that the challenges aren't just at mental health. And I will use the word challenges because they are, and they're things that we have to solve as a group. I'm a public service, I'm paid by the state, so is Jim. We have to work really hard to implement policies. So that said, and just to remind people, in 2009, the amount of money, we couldn't invest in our health services. We were nearly stagnant for a while after all the different crashes, and it was really, really hard. So that's one thing. Then moving on. The second thing is, we've also identified, and people might notice the subtlety of this, there's promotion, prevention and intervention, and then there's the services. So like 10, 15 years ago, I mean, it was just all about services and big institutions 20 years ago. We now recognize the need for promotion. I think also the next 10 years is about getting at the prevention and intervention in the communities, early intervention. If you can help someone early in their illness, it could actually be less traumatic for them in the long run in terms of involuntary detentions, etc. So I would be optimistic. I do agree with what Eddie said earlier about the challenges of implementation. And there is no doubt that the most important factor in delivering is the HSE. That is the single issue, point that we're all dependent on. And so then the job then is to put the structures in place to support and oversee. So I see Jim mentioning about the implementation science, and that's good, because we've presented papers to the HSE and to the minister and to the department, and all we want to do is give our view and then try and support people to see that view and help it happen. There is no doubt that this is a large scale project over the next 10 years. Like, it's a really big project. So there, and the other thing I'd like to say is the capital investment for me. I mean, my career, God, I don't know where it went, but my career will be over in 10 years. And what I would love to see is that everyone goes into a proper building. Now, we've 75% of the buildings in a good place. The last 25%, if we could just get the capital investment right, and I understand it takes time, but just have a plan there that we know whoever needs help gets it in a particular way. I also want to come back to the concept of universality and equity, and people talked about integration. We've been trying for a long time as a state, and Sláinte Care is trying to create universality and equity. We have to be careful, because we're struggling to deliver services in the here and now, that we don't drift away from that long-term goal. So if you look at, for example, our inpatient acute mental health beds, a good few of those beds are really only available to people who have VHI. Now, you know, and some of our biggest institutions are really only available, not VHI, you know, who have private health insurance. But that said, if you compare us internationally, generally people all over the country have access to inpatient beds. Then finally, one thing is, we have a real challenge, and it's not just mental health as a country. I would love us to see it be a country of excellence where we attract people from all over the world to be part of our services. The HR challenge, and we all know it at the moment, the churn that's going on, attracting in and mechanisms and creative mechanisms to attract in the best staff to support us over the next 10 years, I think is going to be the key challenge. But you know what? We will do our best to support people. In terms of the new act, I'm looking forward to regulating community services. And the reason we will have to regulate to improve. So the idea of there will be a lens on it and regulate in a way that doesn't, you see, you have to be careful you don't harm people as they're trying to do the right thing. If you think of Kerry Cams recently, and I know there's a review and the inspector is doing a review, but you're trying to bring it on while keeping the people, the good people who are there trying to do a job. So it's a balance. I absolutely appreciate if people say we've so much to do, and we do, but I genuinely feel that there's enough people with enough experience that we can oversee and push this the right way.
John, you've heard from 4 people, and you've heard, I think, similarity in terms of the big issues, challenges, call you what you wish, in the next 10 years. Jim, if I can just come back to you for a moment. I mentioned earlier on, Jim, you're one of the lead implementers in sharing division within the HSE, and as everyone knows, the HSE has responsibility for the vast majority of the recommendations in sharing division. Would you maybe suggest to us what you think are the big issues for the next 10 years in terms of implementation from the perspective of the statutory provider?
Thanks, Johnny. Okay. So when I looked at sharing the vision, having looked at Vision for Change, and unfortunately been around at the implementation of that as well, one of the key things we needed to make sure was that we actually had something like a little bit more like SMART objectives. Because one of the criticisms that there is of the implementation of public policy is that, do we know if we're there yet? So one of the things we've done already is that we've looked at every one of the 100-odd recommendations, and 83 of which are in for the HSE, which will amount to about 146 actions. We're trying to break it down into actual actions, saying, well, by that we mean the following. So how will people experience the change that we're talking about? Because some of the change that's involved in these things are structural changes. But what it really boils down to is, how will the service user, their family and their carers, how will they actually experience our mental health services differently? So we've been really keen on learning from the previous, and not just within health and not just nationally, but internationally, about what works from the perspective of implementation. Part of that is about having consistent persistence, dogged, stubborn approach to change. That is the day in, day out, sometimes mundane, but always essential working. My view is that we need to embed the sharing division in the everyday work of mental health services, because it's not something separate. It's actually something actually embedded. So the sort of challenges, and I accept Eddie's point about hate using the word challenges. So the big issues for me are, we also have a wide variety of stakeholders. Not everybody sees the world the same way as the people on this call see it. They have different perspectives. And so from that point of view, I need to take those into account, identifying the first instance where those logjams are, and then try and work through them. And John, as you know, the group that you chair, the NIMC, will form part of that, the implementation and monitoring the implementation, but also about making sure that outside of the HSE, what are the barriers that we need to be able to address? And I can see from the chat that's going on there about people asking about recruitment. And while I won't delay too long on it, two of the things that we have done over the last number of years is that the mental health services have invested in additional training places for psychologists, for psychiatrists, and for psychiatric nursing, and to significant improvement. This year, for the first time, we have 46 individuals coming out of higher service training to be qualified as consultants. I met with them all last week with my colleagues from around the country. We did as good a job as Board Forge did on encouraging them to stay in the country to provide services within this country, at least, or if not, if they do go abroad for training, that they would come back. So we've done that in psychiatry. We've done it in psychology through the development of psychology assistant posts. And we invest about 5 million a year in assistant psychologists. And in psychiatric nursing, we're investing similarly about 4.5 million a year on increasing the number of posts. Excuse me, that students going through the systems in nursing. So we need to increase the pool of available staff. We also have to look at the models in which we're utilizing to make sure that they're now fit for purpose. And then finally, the method that we're using. So that's where the likes of the online does help to try and deal with, let's say, the lower level issues and make sure that for those who do need face-to-face that we're able to provide it. So John, I hope I've covered some of the issues there that I think are going to be an interesting period of time. But the final thing I suppose I want to say is the commitment from the HSE. I had to do a presentation to the board recently on the implementation sharing division and other issues in mental health. And they're extremely concerned, and they're also very exercised about ensuring that as an organization we deliver on the commitments that we've made. So I do want to say that the commitment is there from the HSE, from the board downwards, and certainly from senior management. And I think the last thing I want to just to agree with John there in relation to the capital planning. I think the last number of years we've really had a negative impact in the way in which we try to plan for our capital developments. But thankfully, one of the things I've been involved in, as you probably know, around the development of the new National Forensic Mental Health Service in Portrane, and we will be opening that in mid-year, which will be a very significant step change for provision of mental health services in the country. So thanks, John.
Thank you, Jim. Just want to come back to Sharon and Michelle. Jim alluded earlier on in his comments there about the impact of services on individuals, people who use the services, and sharing the vision is very grounded in this idea of outcomes. Would you talk a little bit about what you see as the outcomes for the next 10 years or near 10 years in terms of good mental health care services from your perspectives? Michelle?
Okay. I think, moving forward into the next 10 years, that mental health services are accessible to everyone when they need it. They shouldn't be getting to a crisis situation whereby, it's really damaging to their mental health and the mental health of their family and carers. There should be an easier way of accessing mental health services. I hope that with what Jim has just said there, with the numbers of psychologists and psychiatrists, the increase in numbers of those individuals, that this will help to alleviate some of the waiting lists that are really very long indeed, to make sure that people do get the services that they need when they need it. I think we can't forget the children's area of mental health, because we have heard so many stories about children waiting, and maybe inappropriate care being given because they're put into an adult services rather than being maintained into children's mental health. I would hope that we will see developments in those areas, that children are being supported correctly, and also their family members, because it is a very stressful time for family members as well, being able to cope with an adolescent or a young child who is struggling with their mental health, because ultimately it impacts their mental health as well. And if their mental health declines, now you have, a whole family that is not able to function correctly. So I hope with all of the investments and the new people coming on board that we will see improved mental health services for people, but also that there are pathways, because there are other types of services like our own and other organizations here who provide substantial services within the community, that we will get to a point where it should be a seamless service, whether you are coming to the voluntary sector or whether you are going to see your psychiatrist or psychologist or whatever, that if there is referral paths done in the correct manner, it should be seamless to the individual. They shouldn't be left in a distressed situation. If they're going from one side to the other side, it should be just seamless, and that support continues on. And the voluntary sector has a great role to play in that. But I do believe that we need to get a little bit more, I suppose, co-production in a sense, in relation to the referral paths, because I know from our own perspective, Some areas are very good in referring people to us and other organizations, and then other areas are not. So I think there needs to be a shift and a change in thinking and developing those referral paths. We're all here to do a job. Our core piece is the service user. From every perspective, it's the service user. So let's work together and let's make it happen, and that we support those who are in need and the service user in particular. And we all have everything to offer. So let's work together.
Thanks, Michelle. Sharon, I'm going to ask you the same question from your perspective.
And I guess some of my answer actually is quite similar to Michelle's. What I would like to see in 10 years' time for people with mental health difficulties in their families are choices, that they have choices on the type of service they want to access and how they can access that service. And it is quite limited at the moment. Even those services that we do have in place, there's limited knowledge of how to access those services. So that's a big body of work that I think needs to be done. Early intervention is critical, and how we provide that to people is critical. I would also really like to see an increased investment in the lived experience workforce. I think it's really commendable that investment is being put into clinical staff. I would also like to see that extended to lived experience staff working within the mental health services. You know, the opportunity to provide a different type of support within clinical services is very important to families and to people who've had mental health experiences themselves, particularly when they're in clinical settings. I think that there does need to be a balance in the approach that we take within clinical settings, and that lived experience voice can do that. It's something that unfortunately we've seen not only in Ireland again, but we've seen between the lived experience workforce and people with lived experience and the clinical settings where, you know, unfortunately, we talk about things like involuntary admissions and words like catastrophic are thrown around, and it's not helpful. We're all supposed to be working for the same outcomes. And I think, you know, if we can get there in 10 years' time, that'll be a wonderful result.
Thanks, Sharon. We've got about 5 minutes left, and I just want to go back to Jim and John. There's much talk about retirement. In 10 years' time, John first, I think, what do you think you'd be most proud of if you manage to achieve all of your ambitions between now and 2032?
Well, I'd be most proud of if we as a state that all our inpatient acute units were, and we're not that far away from it, gave you hope and preserved your dignity when you went in, and were in such a way that the staff can provide professional services and designed that way. So as I say, we're about 15 centres short of that, and we've come a long way. The second thing is, I think the community mental health teams and services and, you know, really early intervention and multidisciplinary teams. Look, I used to be the charities regulator, so I know the amount of work that goes on in the voluntary sector, but for me, I don't want to forget about that. You need your, you know, psychologists, social workers, psychiatrists, mental health nurses. You need advocacy, that team of, you know, people by experience. I would just love if you could walk out of this house now, me or my son, and we could walk to a place where you could access that service without A&E. So there's community mental health services. And you've seen that during COVID. I think PATS, for example, were rolling out a very good wraparound service out into the home. So it's there to be mimicked. So I would kind of like that. But I do look back. I mean, my parents were both mental health nurses. I grew up beside St. Loman's Hospital. I was involved in moving St. Loman's to Tala. And it really is so, it takes time. But I think it was one of the British economist, Keane, who says, you know, we can't be too long term, because in the long term we're dead. So I would like to see movement as quick as possible. And I just think with the HSE too, that really recognizing and look, I appreciate the amount of work that's gone on there. Really recognizing that point that you need so much extra resources to implement. So for example, when A Vision for Change was published that year, what was it, a number of years ago, it was the cancer strategy was also published. And if you look at the implementation of that by the HSE, it was much more effective than A Vision for Change. So I really do hope and trust we can only put it out there to people that the implementation is invested in strongly.
We'll stick with retirement rather than John Keynes. What's your hope that in 10 years' time, when you look back on achievements that you'll be most proud of?
The word retirement, John, you're using it a lot. I don't know, is there something, is there a message or something? I think if so, I'd break it down into bite-sized chunks, because 10 years to me is a very long time away. 3 years ago, we didn't know we were going to have a pandemic, and now a war that we're responding to. And the services have had to do that over the last couple of years, and I think have responded quite well. I think the things that I'd be proud of, the service user engagement to me is the critical bit, because it does change the way in which we see the development, first of all, and the actual implementation of mental health services. And if we're guided by that, the way we have been over the last number of years, I think that would be something that I think that as personally and as an organization, we'd be very proud of. But the final bit, from my point of view, I think as a learning organization, what did we learn from implementing sharing the vision Vision for Change and Connecting for Life? And it is about that dogged, ongoing, day in, day out work, which is around change. And that change isn't easy, and it will only be felt across all of our teams. So it's the structures we put in place, the accountability that Eddie has mentioned earlier, I completely agree with. We have to be accountable, and we are accountable. But the sustained investment, and I must say that over the last 10 years, we've had very significant additional investment in mental health, despite sometimes what people would say. And that's been continued in the last couple of years. And I think that's something that we need to continue over the next number of years, because if you do it in a sustained way, then you can make progress. And the final bit is around the recruitment of staff that are appropriately trained, and that there are enough of them to make sure that they can actually deliver the services in premises that are fit for purpose. So they're the things, John, that I would like to look back, if it was in 10 years' time, that I'd be most proud of.
Karen, I'm just going to ask you, from the point of view of the reference group, which you're going to be very busy with over the next couple of years, what do you hope will be the outcome that you'll be most proud of?
Well, I think the establishment of the group in the first place is something to be proud of, and the makeup of the group themselves. A lot of work has gone into the formation of the group, and I think, you know, having met last week for the first time, the skill set and the passion and the commitment that are there, I'm already proud of that, to be honest with you. Looking forward, we know it's a huge task, but it's like, you know, eating the elephant one bite at a time, and everyone is really looking forward to it. You know, how can we have the most impact? Where can we have the most impact? And, you know, just working together collectively over the next few years to try and make that difference.
Michelle, same question to you.
Well, over the next 10 years, I hope that mental health reform and the member organisations, you know, will have hopefully have achieved everything that we have set. We will be setting out in strategy, and, you know, in relation to government policies, you know, making sure that they are delivered upon, and getting our voices heard, you know, and being a partner in relation to policy development as well, because I think it's really important that everybody has their say in relation to how policy is developed, and how that will look in relation to what it means to every organisation and every individual. So I think mental health reform has a huge part to play in relation to that. It also has a part to play in relation to the service user's voice being heard. It does a great job on that, but we can always improve upon that, getting more service users out there, having their voice heard, empowering them, so enabling that change to take place, because it's their lived experience that we want to build upon. We also want to ensure that the services we develop into the future are around the service user and their lived experience, what was challenging to them, what worked for them, what didn't work for them, and how that can be actually brought into day-to-day delivery of services into the future. And I think, you know, all of our hearts are in the right place. Sometimes it can be frustrating, there's no doubt about it. But I think once we keep our vision in front of us and what we want to try and achieve, we will get there. There might be a few humps and bumps in the way, but that's life. But we will get there, and that's what I would like to see. And that in some respects, you know, if mental health reform does its job, there should really be no need for a mental health reform organization into the future if everything that we are seeking for, then there is no job for mental health reform. I don't think that day will ever come, but
Okay.
that's, you know, that's what every organization in the voluntary sector is about, that someday we will no longer be needed because everything is in the right place for the right reason.
Thank you, Michelle. So we've heard from the four panelists, and we've heard that there are issues, challenges, and we have identified some of them around consistency, around access to services, around having meaningful outputs and outcomes for people so that people actually benefit from the service that's been provided. We know there's issues around recruitment and so on. But we've also heard some very hopeful statements from all four about the possibility of overcoming these issues in the future and producing a service that people can be proud of in terms of delivering what's needed for people at the right time, at the right place, to quote an old phrase. So I just want to thank, on your behalf and on behalf of everybody tuned in here, our panelists in the studio here. We have Michelle, from GROW, Sharon from Mental Health Reference Group, Jim Ryan from the HSE, and John Farley from Mental Health Commission. Please show your appreciation. Thank you very much.